This next session is what's called a quick fire hub. And we've got some real innovative leaders here from UCLPartners who are going to talk about some amazing solutions. And I've had quite a few previews of this that are really practical to help improve cardiovascular outcomes. Laura's going to chair this session for us. So without further ado, I'll introduce Laura Boyd. She's Director of Implementation for the Cardiovascular Health Programme at UCLP, and she'll allow all her learned colleagues to introduce themselves. What I love about this is it's practical and it's doable, it's transferable and it's scalable.
Thanks, Angela. So I'm delighted to chair this session. We're going to focus on cardiovascular health and innovation. As Angela said, my name's Laura Boyd and I'm Director of Implementation for Cardiovascular Health at UCLPartners. I'm going to let them both introduce themselves when they stand up to speak, but I'm joined with by Dr Matt Kearney, Executive Clinical Director and GP at UCLPartners, and Dr Umar Ahmad, who is founder and Chief Executive of Apptrace, and he's going to tell you about that fantastic digital solution shortly. So just a couple of words about UCLPartners. You met Richard earlier this afternoon, who's from Yorkshire and Humber Academic Health Science Network. UCLPartners is not dissimilar, kind of the equivalent, covering North Central and North East London and parts of Mid and South Essex. We cover a population of 5.5 million, and our role is really to accelerate innovation into practice for greater patient benefit. Just before the start of COVID, we adopted cardiovascular health as a major priority for UCLPartners. And why is that? Well, I probably don't need to tell you, it causes more than 25% of all deaths in the UK. It's a major driver of inequalities. And it's a cause and an issue that's at the heart of many of our partners across North Central, North East London and Essex. I'm really excited by this panel because the closing remarks of Claire before the break was know your population and prioritise accordingly. And I think the two innovations you're about to hear from really bring that to heart and bring that to life. So without further ado, I'm going to hand to Umar to say a few words from Apptrace.
So thanks for having us. My name is Umar. I'm the CEO of Apptrace, and I'm an NHS doctor. And so for those of you that don't know Apptrace, we are a startup, and I guess that's why I'm here speaking to you, to give you a startup perspective. And so we cover 2.7 million patients across the UK with delivering software for primary care for GP surgeries up and down the country to help deliver better care across the country. So we analyze data for 2.7 million patients every day across 30 ICSs with a UKCA marked medical device, software as medical device, that is integrated with 96% of the UK population, so primary care health records across that population. So the reason I, as a doctor and colleagues, formed Apptrace was I kept seeing people in hospital that I was seeing that had come to us far too late in the journey, where they were sick enough to need hospital or call their GP with a reactive appointment where they felt something was wrong. And I think for this audience, it's not controversial to say that we should be earlier in the journey, where we should be monitoring known existing chronic disease better, so deterioration is found as early as possible and treated as early as possible. Or we should be detecting cancer or other new diseases as early as we can, where treatment is more effective, or preventing disease altogether by putting people on very well evidenced therapies that they're not getting access to, as has been mentioned. But if you're asking primary care or any doctors to deliver even better quality in a workforce crisis, then you need to give them some way of enabling that. And a digital solution, we think, has to be part of that story. As a clinician, what I'm expected to do is to know the entire patient, to see everything about that patient that's within their EHR in a 9-minute consultation. And then I'm supposed to know all the guidelines and deliver the care according to those guidelines for all those patients, or with the help of experience. And then I'm supposed to deliver various pathways, whether they be about prevention, early detection, or monitoring of existing disease. And that's what our machine does. By integrating into the patient record, we're able to pull out all of the relevant information, every disease that the patient has in real time, every drug that they're on, every consultation that occurs, every observation that's taken. And we're able to process that against encoded clinical guidelines and, using machine learning, new information about risk factors that patient might be developing. Pick that up, and then we deliver back to the clinician integrated software that is tailored for that individual clinician type. Rather than a one-size-fits-all, and for each individual pathway. And that's all integrated into the EHR. And each time we close that loop, it improves. So our first product finds all these patients who potentially have cardiovascular disease and detects them, brings them in at the right time, but not just as an individual disease, but as a patient as a whole. Make sure the right people come in at the right time, and then make sure they leave with everything done in an automated way without the involvement of a doctor. And then detecting new patients who now may have developed a disease that they should be referred for. And there's a problem. So 6 million patients in the UK are overdue something that we know that they should have had. And yet we're wasting 2/3 of appointments because we're doing that suboptimally. People are coming in, having some of the tests done, leaving, and then having to come back again. So what we can do if we were getting this right was we could save potentially 30 million appointments in primary care each year, and that's capacity that we sorely need. Not only can we deliver this care, we can measure that improvement day on day. So we can see people logging on, and we can see the backlog dropping. And so far we've seen that we've impacted 300,000 patients in 1 year alone. And because the product is integrated and it's focused on the use case, we've got good acceptability for individual users and also for practices. So the reason practices like using us is because we reduce the cost of care delivery by removing the duplication. We improve the quality that's achieved, and we remove the cognitive burden that they're struggling with, that their clinicians are trying to manage, and all of the burnout that comes with that. So finally, this is an integrated care systems talk, right? So when you talk about measuring quality, we measure every single appointment and we give that back to the practice, and we say, you saw 200 patients, this many patients were suboptimally handled and they are red or yellow, and this many patients are green. And we can show that every week for an individual practice, for an individual clinician, but also for practices within a PCN or PCNs within an ICS. And so you really understand at an individual patient level, but at a population scale, day on day, what's happening, what needs to happen, what really is happening. And that, I think, has huge potential as a way of planning and improving our strategy. And so finally, we as a startup have been supported by a whole system, an ecosystem around us, whether that's AHSNs like UCLP or the NHS Innovation Accelerator or funding bodies like Innovate UK. And that's what's allowed us to grow from 15,000 to 2.7 million patients. And I've got a million other asks, I'm sure. But I think that this is hopefully a source of hope and when we talk about these massive challenges that we're trying to deliver. So thanks for having us, and look forward to discussions.
So Matt Kearney, I'm a GP, Executive Clinical Director at UCLPartners. I was the previous National Clinical Director for CVD Prevention, so a big focus of my work in recent years has been on preventing heart attacks and strokes. And we heard at the beginning what a huge burden that is and what a huge challenge that is. I think the challenge to all of us is how we reach a step change, because we know if we were to achieve a step change, because we could actually prevent thousands of heart attacks and strokes in England in 3 years, hundreds in every ICB, strokes and heart attacks that devastate people's lives and often result in premature death and cost huge amounts of money. So that's our starting point was the data, as Chris Hoffman said. What is the problem? That is a huge problem. And it hasn't appeared solvable in the past. We've tolerated quite low levels of achievement. Our focus in UCLPartners in building the proactive care frameworks and other tools has been on how do we support primary care to do things differently, not just reiterate what the guidance says or what our expectation is or what the population health problem is, but how do we do it in the real world. Cardiovascular disease can be prevented, we know, by lifestyle things, smoking and physical activity, but also blood pressure, cholesterol, diabetes. These are major drivers of premature death from heart attack and stroke. They're all very treatable, and if you treat them appropriately, if you follow the nice guidance, you prevent lots of heart attacks and strokes. But actually, we tolerate late diagnosis, substantial suboptimal treatment, substantial variation as a driver in itself of inequalities, and it's been entrenched for decades with little progress. If only we could implement the last but one or last but two nice guidance for hypertension, we would prevent a lot of heart attacks and strokes. So our challenge to ourselves as COVID hit was, we want to help primary care cope with COVID. How can we take that opportunity to transform in primary care to do things differently at scale, not just by reiterating the ask and the tell, but actually understanding what you need to change in primary care. We're also poor at supporting self-management, etc. But the critical acknowledgement is that it's because this stuff is really hard to do in day-to-day general practice. And we don't generally acknowledge that. We assume a magic happens. We produce the guidance. The magic will happen at primary care, and if it doesn't, we don't understand why. Size of the prize, there's one for every ICS in the country for blood pressure and one coming for cholesterol. It shows before COVID, about 70% of people with hypertension had their blood pressure treated optimally. How this dropped to under 50%, it's the same basically across the country. How 21 months after that dip, we'd only got back up to 62% nationally. And if you take ambition 1, assuming we get back to the pre-COVID recovery position, we will prevent thousands of heart attacks and strokes across England. Or put it the other way, if we don't get back to that recovery, that's the additional heart attacks and strokes that health and social care will be paying for in the coming 3 years. And size of the prize shows a trajectory of ambitions beyond. In developing the proactive care frameworks, we considered, why is this hard to do in primary care? What framework that we can develop that's locally adaptable, that will support primary care to do things differently? So 3 core elements: stratify your population, use smart data to understand who's at highest care so that you can need and risk so you can prioritize. Secondly, deploy this fantastic wider workforce that we have to do the stuff that we as GPs do badly. We don't have time to do in our 8 or 9 minute consultation. So structured support for education, self-management, behavior change. And then to focus on, reflect Claire Fuller's report around the critical need. If we want to deliver ambitions in primary care, you've got to have structured implementation, support and resources to make that happen. So in UCLPartners and with our partner HSNs, we absolutely focused on providing that wider support, not just expecting GPs to take the resource and run with it. So this is what the framework looks like. It just, a quick 1-slide summary, but across the 4 conditions for the cardiovascular disease, we've got for about 8 conditions now, but stratify, we've built the search tools, they're in use multiple all around the country. And that feeds into the lower boxes so that your clinicians then bring patients in and optimize them, not on the anniversary of their last birthday, but according to their needs. That helps manage capacity in primary care and deliver the optimization, because we know there's a straight line of evidence between optimized blood pressure, optimized cholesterol, you prevent heart attacks and strokes. If we want to look for outcomes, actually, if you optimize the care and you show that, 2 or 3 years later, you will see the population health impact. So it's a really straight evidential line. But much of the innovation is in that upper box, so using the wider workforce, as I mentioned before, to support education, self-management, behavior change. What does blood pressure mean? What is cholesterol? How do I take my blood pressure? How do I check my feet for diabetes complications? All the stuff that's really critical, but when do we have the time to do that in consultations? So we've tried to systematize that for use by wider staff in practices. So it improves the care for patients, and this prioritization approach increases capacity at the front line. And I think it's partly because that's how it's viewed. The uptake has been really substantial across England. So 16,000 downloads of the search tools. In the blood pressure optimization program that ran nationally across all the HSNs using these frameworks, almost half of PCNs in the country are using the framework approach. It's not to say they're doing everything, but they're signed up to doing that. And we've received some national recognition in awards. And I think it's partly because it's seen as self-evidently developed by people in primary care with patient and public insight in the development. And it's locally adaptable, it's not a prescription. But also because it's not a new ask. And always GPs acknowledge this is not a new ask. You're actually helping us to deliver our business as usual. And I think at this time of zero capacity during COVID, that was absolutely critical. And this trajectory of happened despite and all through COVID. Those are the proactive care frameworks that we've developed. We've developed a new tool, which we're just about to pilot in London and across the country, called CVD Action. And it's building on the principle. We have those core elements of the framework approach, but if we want to prevent heart attacks and strokes at scale, we need good, smart data that tells us who the patients are so we can find them, bring them in and optimize their care. So CVD Action does this in a really sophisticated way and brings in multimorbidity, etc. But it helps GPs say, these are the patients. Don't worry about all your patients with hypertension. This 18% are very high risk. This 20% of people with CVD are at very high risk because they're not on statins. Go to them first. You'll see your heart attacks and strokes drop in 3 years. So it helps that targeting, but also the prioritization helps to make it manageable workload because they can choose, GPs and their teams can choose what they're focusing on. But there's a strong health and equalities element in there. As Laura said, health and equalities CVD is a major driver of health inequalities. With this data, you can filter by severe mental illness, by ethnicity, by deprivation group. So at a PCN, you can focus right in on this population who's at greatest need. So we're piloting this in London. 2 core elements to the piloting. One is, here's the sophisticated data tool. But secondly, here is the support to help you deliver it, with business intelligence support, facilitation, additional clinical support, like IQVIA provide across the country, for example, additional pharmacist support. So all the stuff to help to make it happen. And so we're piloting that. But final slide. So we have this framework approach, the locally adaptable, but the focus is on how you do things differently at scale. And I think there's questions to be asked about how do we actually make this happen at scale and ensure that it's happening systematically across the country. But then secondly, use this smart data approach to find the patients. And these numbers are really quite staggering. So the top line, if we could increase from our current position of 62% people with hypertension optimized to target as nice as they should be, we would prevent 7,900 heart attacks and almost 12,000 strokes in 3 years. I mean, consider the local authority savings just in those numbers alone, for example. And similarly, with people who already have cardiovascular disease, everyone should be on a statin. It should be almost in the water because it prevents so many deaths, but 20% are not even on any statin dose. So just getting that up to 90% would prevent another 19,000 strokes and heart attacks in 3 years. The question has to be, are we going to continue to tolerate what we've tolerated for decades, the suboptimal treatment that we just say is, that's primary care, it's difficult to do, variation's normal? Or are we going to say, how do we make this step change happen? And I think we have to plump for the latter. We have tools now, we have an opportunity with the transformation that's happening in primary care. So that's a challenge to us as GPs and UCLP. It should be a challenge to all of us, I think, because the population health benefits are potentially huge and dramatic. So thank you very much. That's the last slide. So,
thank you, Matt. So thanks to Matt and thanks to Umar. Just a couple of reflections from me. One is, I've worked with Matt for probably 3.5 years now, but I'm always struck by the recognition that it's challenging, it's difficult. Because I think once we recognise that, we've got an objective place and a set base to move on to start tackling that. The second thing I want to say is, and I should have said this at the beginning, the eagle-eyed of you will have observed that we should have been joined by a colleague from the British Heart Foundation who unfortunately wasn't able to join at quite short notice. So I'm going to kick off the questions with a question that I imagine John might have asked, which is really around the patient and the citizen. So you've both described innovations and work to support the system itself, but through that work, how do you keep the patient, the system, the end beneficiary central to that work? Umar, let's go first.
So I think a number of ways. First is in the design stage of asking the patients, is this what they expect? Is this the expectation about use of data? And we did an exercise, PPI groups, PPG groups, trying to understand if that's what patients wanted us to do. But also trying to understand from patients what the expected impact is, because we measure things like, compliance or guide against, achievement against guidance. But actually, there's a patient experience part of this. If you're coming into a practice, having a blood test done, and then receiving a message the next week to say you're due a blood test, you feel quite frustrated. You feel that the healthcare system is not actually, it doesn't understand, and that's not your experience in other parts of your life. So actually, there's a lot of other patient impacts that we were able to capture and to try and measure in what we're doing, because I think that's important. So I think that's probably some of the ways that we're trying to tackle that.
Yes, absolutely central, and it has to be. And I think it's one of the reasons our frameworks have landed well, because it's evident that there has been that patient input. So in UCLPartners, we've got a strong patient and public involvement group that have brought really quite active input into the development of our resources and testing the resources and helping to modify the resources. And that's been at several steps. We've worked closely with the British Heart Foundation, and of course we bring a very strong patient voice to the table, as with other charities. But as I mentioned, I think critical to this framework approach is it has to be locally adaptable. This won't work as a blueprint. But one of the core elements of the framework is using the wider workforce, not just to systematise, education, self-management, behaviour change, but actually to support different relationships with patients. People like health coaches or care coordinators have very different skill sets from doctors, for example, and nurses, and probably actually are much better at engaging with people and helping to understand their needs and their priorities in consultations. And actually, some of the resources that we've developed are designed to train and support people in those ARS roles to to do health coaching and motivation interviewing, to build those skills so they can engage better with patients. Because there's the transactional stuff about support people to understand their condition, but there's the building better relationship over time and the two-way interaction between clinician or staff member and patient.
Thanks. I'm going to turn to the audience now. If you do have a question, please raise your hand high and Ross will come over the microphone. Yeah, there's one over there.
Thank you. Catherine Keats-Rowan, I'm a local councillor. The two of you have just answered part of the question that was forming in my head, which is to what extent has this been informed by interaction with patients? I mean, as I say, I'm a counsellor, I'm professionally a historian, but for years I have been a patient participant in various forms of medical research. And it does occur to me, that I think I can't remember what you just called them. I was thinking of community champion or something, getting patients to be the purveyors of public health messages, because things like, the basics, attention to exercise, diet, social isolation, all the rest of it, are very, very key in dealing with, diabetes, dementia, and so on and so forth. So it's encouraging to know that, you're on page with that. So my question actually ends up as, what can we in local government do to support this type of thing and making sure that it really takes off everywhere?
So I think there's a couple of areas. So one is just on the first thing that you were discussing, because cardiovascular disease prevention is a big problem. I think there's huge potential to do stuff, as I've described. But we're not going to solve CVD prevention by medics doing it all, by bringing everyone into general practice. So there's 5 million people in England with undiagnosed hypertension. There's 5 million people in England with a cholesterol above 6, so a significantly high level. We're not going to solve that by bringing everyone to see the GP. I mean, there wouldn't be enough room on the phones on a Monday morning to give them all appointments. I think we're going to solve it by democratising health information, by widening access to health information, by using community resources and assets like community champions, for example. So I think to bring your expertise and understanding and insights into how we can adapt the model as we move forward, the model around CVD prevention. We just don't do any of that side of it very well. I think the second thing is, in integrated care systems with shared budgets, I guess there should be an examination. So what is the health economic modelling around this? What are the health implications of allowing 7,000 more people to have a heart attack and stroke in the next 3 years? And what's the impact on local authorities going to be of that? We know it's a challenge for general practice. We can give them tools and resources and support, but actually some of it may need additional funding at the beginning, additional nursing or prescribing support, for example. To get creative about doing things differently at scale, we'll need some resourcing. I think if we can get creative about how we deploy the resourcing, reflecting that this is a system-wide issue, not just a problem for general practice.
I guess the only thing I would add is patients, I think, want to be targeted for the diseases they have. So one of these sort of approaches allows you to find patients with particular conditions, a particular combination of conditions, so that they can be signposted to all the different services that are available to them, and then actually measure the impact of that intervention, whether that's additional support, whether that's a community group, whether that's a digital intervention or an app, whatever it is. I think the problem is that if you treat people in a very rough kind of aggregate way, then you're not able to capture the impact that it's happening, and you're not giving the patient a tailored experience. You're asking them the same questions over and over again that they answered last week on a questionnaire, and they don't feel that they're getting tailored approach. So I think that would both increase patient engagement, but it would also improve the impact of the money that we're spending on providing all these services.
Questions, one here.
Hi, thank you very much. I'm Leah Merceline. I'm a counsellor for Mickleham, Westcott and Oakwood in Mill Valley, but I'm also a researcher and head of pipeline research for the research charity Cure Parkinson's. And my question was really for Umar. Have you thought about integrating research opportunities into your Apptrace? Because I think what is missing from our discussions is how research opportunities can integrate into care options as well as informing care.
Yeah, absolutely. I think that data has been trapped in a silo for a very long time, and once you begin to access it, and it's not easy, you have to integrate, you have to have the regulatory framework for that, and then you have to do all of the cleaning that's required. But you're able to identify these populations, and you're able to identify them sometimes earlier than they would have otherwise been identified. And we also have a stack that contacts the patient with specific information to them. So we have a means of reaching out to those patients. The caveat there is that it's very important that patients are involved in what we're doing. So we're not in the business of research per se, but